This talk is actually dedicated to Gail because she challenged us at the last European Focus Ultrasound Symposium to describe a little bit more of the technical parameters that lead to successful treatment, and so it led to this review. So, Gail, this one's for you. The motivation behind this, obviously, as we've seen today and we've read before, FUS effectively treats osseous metastases, but the response rate in the Hurwitz paper that described the randomized phase 3 results, in the treatment arm we see a 64% response rate at 3 months, and in the sham arm a placebo effect of 20%. Now, in our experience and in the experience of others that have presented results today, the actual response rate is higher than this, and so I was trying to figure out why is there this discrepancy. And of course, there's a learning curve associated with this. There's local factors such as the type of anesthesia that's being used during the treatments. I know in the United States, for example, we were limited to using local anesthesia, which was not a limitation at other sites. And so we would have a treatment that's limited to 3 hours of time, and if the patient's inadequately anesthetized, they may start moving during the treatment as the heating starts to occur, and then you have to replan the treatment, and then suddenly you end up with an ineffective treatment potentially. But this is intention to treat analysis is presented here, and so my hypothesis was that it actually underestimated the true response rate. So I wanted to go back and see if there was a way to assess for the true response rate, accounting for the patients that were suboptimally treated. In order to do this, we obtained all the imaging from all the patients involved in that study. There were 147 patients, 112 of which were treatment patients, and all these images were anonymized so that I didn't know who had done the treatment and so forth, and reviewed all the pre-treatment MRs and CTs, and also reviewed the treatment day MRIs in a blinded fashion. Separately, we had analyzed all the pain data, the medication, and so forth, as well as technical parameters such as the number of sonications, the energies used, the total energy delivered, the duration of the sonications. And at the end of this, obviously broke the blind and then compared imaging features and technical parameters and tried to correlate them with pain relief. And so the images below just show you some of the features that we looked at. You can see it's a right iliac lesion there. That's T2 hyperintense. So that was the kinds of imaging features that I looked at. Was there T2 hyperintensity after treatment? Was there edema in the surrounding muscle? Was it an osteolytic or osteoblastic type lesion? And on the image on the right there, you can see we're looking at the thermal dose as well as the number of sonications and so forth, and lesion location and the type of metastasis it was, blastic versus lytic. So having done all of this, we went and we identified an imaging feature that we call the black band, which basically represents on the T1 weighted fat saturated subtracted post-contrast image you see there. It represents periosteal devascularization. You saw that in some of the earlier images presented today as well. And this correlated very well with the response to treatment. You can see the odds ratio of a complete or partial response in the presence of the black band was significantly higher than in the absence, so an odds ratio of nearly 6 there. And the presence of the black band also predicts successful treatment. The PPV is 72% there. If you look at look at the Hurwitz results and look at the pain scores and how they changed over time, you can see in the sham arm versus the treatment arm, obviously a significant difference between the two. Now what's interesting is if you take that treatment arm and look at those that had black band versus those that didn't. It's essentially the patients that did not have the black band essentially weren't treated. They had no response in their in terms of pain relief there. And so it was an imaging feature that could be used to distinguish an optimal treatment from not. So if after the treatment you see the presence of that subperiosteal devascularization, it's an indication that you've had a technically successful treatment. In terms of parameters, technical parameters, we looked at a feature called the EDBS, so the energy density on the bone surface. It's basically the total energy delivered during the treatment divided by the total area of the bone surface that was sonicated. You can see that in these planning images. I tried to demonstrate what I meant here with this periacetabular and iliac lesion there. You can see in planning there in yellow, I've circled the region of treatment, and there's a bone surface there. So you can use that to potentially calculate the surface area of the bone being treated, and then you can see the individual sonications that have been planned there. Not each sonication is counted. You count the areas where there's no overlap. So if one sonication overlaps for the other, you don't count both. You just count the energy delivered to the surface area once. So this is used to generate this energy density on the bone surface, and this parameter not only correlated well with the presence of the black band. You can see the mean EDBS with the black band was more than double that of without the black band. So, and then also when you have a high EDBS, you can see that the odds ratio of a complete or partial response is also significantly higher. So when the EDBS value is greater than 5, you can see the odds ratio of having complete or partial response is quite high. So with these results, basically what we could see is with a technically successful treatment, in other words, one that has the black band, one in which the EDBS is over 5, the actual clinical response rate that we calculated was 86%. So much more in line with our own practical experience that most patients, the vast majority of the patients respond well to this treatment. And then the other interesting point is that after a suboptimal treatment, so black band negative, low EDBS, the response rate is only 22%, which is basically the same as in the placebo arm. So just repeating the point that I'd made earlier, that in suboptimal treatment, there's no response, basically. It's basically the same as the sham group. So just showing again what the real response rate is, it's not the 64% that was seen in the multi-center intention to treat analysis. In those that are optimally treated, it's closer to 86% there. We also looked at sites that had prior experience prior to entry into the trial, and we looked at some of their practices. Now, they had a nominally higher success rate, which wasn't statistically significant, 73 versus 59%. But those sites that had previously treated patients clinically prior to entry into that trial, they were more likely to use deep sedation. You can see the odds ratio there. They were more likely to achieve a higher EDBS. And what we saw was that the sites with previous experience who used deep sedation during the procedure, they had the tendency to use the even higher EDBSs, so 6.8 value there, and they had achieved the highest response rates of 88% versus 54% for the other groups. And so in conclusion, what we saw is that our hypothesis that the response rate was higher than 64% was confirmed. What we define as really the true response rate was with a technically successful treatment was closer to 86%. And the black band we found was a sensitive imaging parameter, an imaging finding that predicts successful treatment, as shown in the image there with the yellow arrows pointing to the imaging find that I'm referring to. And we also found that the higher EDBS is a successful technical parameter that was really the only independent technical parameter that we found that correlated with the likelihood of a successful treatment of pain relief after treatment. We recommend that EDBS be tracked during treatment. It's not technically feasible to do that right now, but it's something that I encourage the vendors to do and that we're trying to do on ourselves kind of on the back end. And the other thing I noted is that deep anesthesia, basically by allowing the use of a higher EDBS during treatment, significantly increases the rate of successful treatment. Thank you very much.
Thank you very much. And thank you for doing the study. Are there any questions? I have one. The energy density is calculated from what's coming out of the transducer, not the actual exposure at depth.
That's right. It's the energy that's supposedly being delivered. That's correct. Yeah. Okay. Yeah. It could be further optimized by what you're implying.
I might chat to you later.
Exactly. Exactly. Thank you.
But it's a great step forward. Thank you very much.